superior border of the field. So that small field is a lateral, what they call a lateral port here. Remember, we're looking just at treating the larynx, and that is a 6 by 6 centimeter field. That's all we have to do. And there will be a mask on here to keep the patient still. But that shows you the edge, the size of the field. I just wanted to show you those. The other thing, if I can find it again, is I'm going to talk about the cranial nerves. Everybody know what I'm talking about when I talk about the cranial nerves, right? Okay. So why am I talking about cranial nerves when we're doing head and neck? Anybody get any ideas?
Because they control pretty much the rest of the body.
Yeah, but in particular, there's a lot of cranial nerve involvement in the head and neck. Does anybody know what they call a mnemonic for the cranial nerves? Has anybody taught you that one? Preferably a clean one, because I know I was taught two. One which is a clean one and one which is risque, to say the least. So we'll go with the clean one, okay? So let me just get what I'm looking for here. And
I think
then
the brother one is the risque one, isn't it?
which
My brother.
no, I don't know that one, but we'll
Something
just
about breast.
yeah. Well, that's probably one of them. Yeah, there's a lot of them floating around. So let me just get into my head and neck folders here. So here's the. Coming up in a couple of minutes will be the cranial nerve picture. It's coming, honest, it is coming. Did you see that? Oh, it's getting a bit brighter. There we go. So, this is why we tend to look a little more closely at the cranial nerve when we're doing head and neck. Because you notice that apart from the eye and the ear, all of the cranial nerves service an area we will be treating in the head and neck. So the tumors can actually push the nerves or invade the nerves. So we have to be extremely careful about what we're doing. And the surgeons, if they go ahead and do surgery, then obviously they also have to be careful of the nerves. So let me get my list and my mnemonic. So here is a list, and I'll send you all this stuff, but on Old Olympus towering top, a Finn and German viewed some hops. That's relatively clean, I guess. So here is number one, cranial nerve, which is the olfactory. Number two is the optic. Number three is the ocular motor. Number four is the trochlear. Next one should be 5, the trigeminal. I'll change that before I give it to you. Number 6 is abducens, facial, auditory, glossopharyngeal, vagus, spinal accessory, and hypoglossal. So that's the 12 cranial nerves and the mnemonic. So if you remember that, if you remember the mnemonic, you'll at least know what the first letter of the nerve has to be. There are some which have the two different names. And if I can find it in the book, here it is. So let's see. Sorry, I'm blocking people's view here. Big stuff. So 8 is auditory, and 8 in this book is vestibular cochlear. And auditory, obviously, makes sense. So look at that. Once I give it to you, look at the thing in your book, because these will come up several times during the next couple of years, or next year, I should say. So what I was going to do today was go over a few things and review a few things of what we did just the last week. So I'm going to start with this one, which is detecting oral cancer. Remember we were talking about the dentists doing the exams? Well, this is actually from a dental perspective. As you can see, National Institute of Dental and Craniofacial Research. Okay. That's the new one. Okay. So 30,000 approximately new cases diagnosed annually. 8,000 deaths per year. 5-year survival for this type of cancer is 50% approximately. Localized disease, 76%. Metastatic disease, 19%. So what does that mean? What is localized disease, first of all? What do we mean if we say something, a disease, whether it be head and neck or chest or esophagus or whatever it happens to be, is localized?
It stays in one area, it doesn't spread?
It stayed in the, stayed in one area. Okay, it stayed in the area which was actually raised in. Yes, that's correct. And metastatic disease?
It spreads to other areas?
It spread to other areas. Yeah. Okay. So if it spread, say we have a nasopharyngeal tumor from the nasopharynx. So localized disease would be only in the nasopharynx and perhaps the nodes around it. But metastatic disease, it may travel to the lungs, it may travel to the brain, it may travel to the bone. Would that mean that it is bone cancer or brain cancer? What did it mean?
Still nasopharynx.
Still nasopharynx. So how would you term that? If somebody asked you, how would you tell somebody that this particular disease is now traveled to the brain? So you have nasopharynx, but it's in the brain. So what would you call that?
Metastatic.
Brain metastasis.
Brain metastasis from nasopharynx. So it wouldn't be a brain tumor, it wouldn't be a brain cancer. It would be cancer of the nasopharynx metastasizing to brain. That's how you would put it. There is some people out there that say, well, you know, my great aunt Susie had breast cancer and then she had brain cancer. and then she had spine cancer. Nah. Great Aunt Susie unfortunately had breast cancer, which metastasized to the brain and metastasized to the spine, but it's still breast cancer. Okay. People still say that, so I just wanted to clarify it. So, tissue changes in the mouth that may signal cancer can be seen and felt easily. That's the one good thing about it. So again, and again. Oh, I'm sorry, I went backwards. Okay, so leukoplakia and erythroplakia. We discussed these last week. What are they and what's the difference?
Splotches inside the well. When we were looking at it, was inside the mouth.
Splotches. Okay, splotches.
One of them are white dots and the other one are red dots.
Okay, yeah. They're precancerous conditions. The leukoplakia, as its name suggests, leukoplakia, white nodules. Erythroplakia, because erythro is red, so they're red splotches. They're red pimple type things. And they're both precancerous. So if the dentist picks them up, or the dental hygienist, or whoever happens to be there, picks them up, then something should be done. So, other possible warning signs: lump or thickening of oral soft tissue, soreness or lump in throat, because depending on where you happen to be, because the dentist, remember, is checking the mouth and checking the nose, supposedly. Difficulty chewing or swallowing. That makes sense. What about ear pain? Why the heck ear pain?
Because your ears are connected to your oral cavity.
How?
Through the,
Eustachian tubes.
yes.
Okay, yeah, that's good. Difficulty moving jaw or tongue. That usually it means that the tumor may be stopping the mouth from opening or stopping the tongue from moving, which means probably the tumor has spread to the tongue or spread, perhaps pushing the nerves that actually make the jaw open or help the jaw to open. Hoarseness, again, makes sense if you have a sore, difficulty in swallowing or chewing, and if you have a soreness or lump in the throat, of course you're going to be hoarse. Numbness of tongue or mouth, that again is a sign that it might have nerve involvement. And the swelling of the jaw.
So would that carry over to possibly losing taste? So the food doesn't taste the same?
Usually not. Usually it's the treatment that causes the difference in taste. But it could, but not usually. Okay, risk factors. Tobacco use, alcohol use, exposure to sunlight, age, gender, and race. So age is 60-ish, thereabouts. Gender is mainly male. And race, unfortunately, mainly white. In this country, anyway. So head and neck exams should be a routine part of dental and medical checkup. You have to take a history of alcohol and tobacco use and follow up on suspicious signs, which we just went over. So how would you get the history of tobacco use and alcohol use? So how many drinks do you have? Who's going to tell the truth? Probably nobody. So, usually it's with a little note at the bottom, at the side saying, patient states. So he's a social drinker, that's the good one. That's the normal one, social drinker. You tell me what a social drinker is. I don't know. It varies from person to person. What some person might call a social drinker, other might call a heavy drinker. And tobacco use.
If you're social every night, I mean, that makes sense.
Yeah, exactly. Well, some people drink wine with dinner every night. Some people have a couple of beers every night. Is that a social drinker? It depends on your terminology and where you come from. Tobacco use. How do you term tobacco use? Obviously, you ask the patient how many cigarettes they smoke in a day. So, what's in a pack? How many cigarettes in a pack?
20.
20, okay.
I was gonna say 12, I don't know.
I don't know. I've lost track because the only person who smoked in my family was my dad, and he's passed away. So, 20 cigarettes in a pack. How many packs do people who say they're a moderate smoker say they smoke?
Maybe a pack a day.
Pack a day, that probably would be good. Yeah, that would probably be counted as a moderate smoker. Some people smoke 3 packs a day. Yeah, I know. If you look in, I was reading a story about John Wayne the other day, and he actually managed to smoke 4 packs a day. How he did it, I really don't know. But, yeah. So what you do is you don't put down in the history that they're a 2-pack a day smoker. It's a pack a year, So if you do, say, 1 pack a day, then it would be 365 packs. That's a lot. And unfortunately, most of the head and neck patients are smokers and drinkers. So tools, this is looking at the mouth from a dentist's point of view, or a dental hygienist. So proper lighting, obviously, you've all been to the dentist and you have these lights shining in your face. Dental mouth mirror. What does that look like?
Little
A dental-
circular thingy, that's the little circular mirror thing that's angled so they can look in your mouth.
Yeah, so it's on a holder, right, and it's sort of angled. Gauze squares, which is what they use to hold your tongue. Do that. Gloves, and 5 minutes. That's all it's supposed to take. 5 minutes. So, intraoral exam. What is he or she looking for there?
Swelling.
Pardon?
Swelling.
Swelling
Lumps.
of what?
The lymph nodes.
Which lymph nodes is they actually looking at there? Or feeling there? What are the lymph nodes under here called? Sorry?
Paras, I can't remember what it is.
Okay.
Paras something.
Anybody get any ideas? What would those nodes be? Those are the ones right under here.
Aren't they near the
Sorry,
salivary
right
glands
under
that are
here.
there?
No. Salivary glands are up here. They're the submental nodes.
See, I couldn't remember what the bottom, underneath the jaw.
Yeah. So they're right under the mandible.
Yeah.
They can be either the submandibular nodes or the submental nodes. Some are here and some are here. So it looks as if he's covering both of them. Okay, the lips. Is there any problems in the lips? If you had a lip cancer, you could see it there, or at least an external lip cancer. You can see it there. We were talking about pipe smokers. Usually, their lip lesions are either on this corner or this corner, because that's where the pipe hangs, either on this side or this side, right? Okay. So, labial mucosa, nice and clean by the looks of it. Nice and clean teeth. It's probably done just after they got cleaned. You want to have a good picture for this, right? So, what's this? This little thing here. What's that called? The little thing that is up here.
Frenulum?
And again, on the bottom, still looks reasonably good. There's something just here. But it could just be the way he's pulling the lip down. And to the side, buccal mucosa. Where's the buccal mucosa? Right here. True story. I asked one of the students in a former class where the buccal mucosa was. And they were deadly serious when he answered me. Where do you think he said?
What's he?
Here. Buccal mucosa. And I looked at him and I thought he was being, because he's a little bit of a joker, and I looked at him and said, "You're being funny, right?" And no. I still think he was being funny, but anyway. So here's your buccal mucosa. So this is looking good. So this is one side of the cheek and the other side. And then the gingiva, perioral and intraoral, soft tissue, and the tongue. Everything looks good. So if we had something, there's something there, but it could just be the light. It looks a little white. And the side of the tongue. Now normally, if we have what's called the floor mouth or a tongue tumor, it can be, because here's the floor mouth here, and the tongue is here. So sometimes the tumors can start about here in the tongue and then migrate down the floor mouth or backwards. So they start on the floor mouth and work up to the tongue. That's why when you're treating floor mouth, you always include the tongue. And there's the right side of the tongue with the famous gauze swabs. And the ventral surface of the tongue, so looping underneath the tongue. Everything looks good there. And the floor of mouth. So the tongue's up. Tongue's up here. So this is the floor of mouth. Hard palate. I still say there's something floating up here. But so this is the hard palate. And then they look back to the oral pharynx. He's quite a bit of fillings done. So looking back to the oral pharynx. And they're checking the one finger in the mouth, one finger under here, and they're checking to see how things are. Okay. Oral lesions. Homogeneous leukoplakia. What would you think that might be? What's homogeneous? What would you think homogeneous might mean? it can be done, it can be used in various different areas. In physics, it can be used homogeneous. It can be used in anatomy. It can be used in oncology. What does homogeneous mean? Anybody, any
The
ideas?
same.
But it,
It means the same.
the same, okay, yeah. So in physics, if you have a homogeneous beam, the beam's all the same energy. Here, it would mean that the leukoplakia is spread throughout the area. It's all the same. So leukoplakia, as I mentioned before, is a precancerous condition. Leukoplakia with early squamous cell carcinoma. So you not only have precancerous condition, but you also have actual cancer in the same area. Nodular leukoplakia with severe epithelial dysplasia. Okay, so what's dysplasia? Dysplasia means that the cells aren't looking like the normal cells in that area.
They're growing normally.
They're growing abnormally. So you have leukoplakia that's little nodules, and epithelial dysplasia, which is certainly even more so a precancerous condition. And then you have erythroplakia with candida infection. So erythroplakia, we decided, was red nodules. What is candida?
Yeast infection.
Yeast. What type of yeast? What would you call it in the mouth? Thrush. Yeah, thrush. That's what it's usually called. Okay, so here's homogeneous leukoplakia. You can see it's all one area, and it's not in little nodules or splotches. It's all together. That's homogeneous leukoplakia. So here again is leukoplakia around here. This is an early squamous cell carcinoma here. You can see it. And this is leukoplakia, so nodular, you see it sort of in little nodules. And epithelial dysplasia, so it doesn't look like the normal cells here. And here is erythroplakia, the red part, with thrush candida infection. Okay. Oh, that's okay. So, makes sense. So that's what the dentist is supposed to do. Whether the dentists do or not is a different matter, but that's what they're supposed to do these days. And I did check with my dental colleague, and all of the dentists that he works with, sending his students out, they all do that. And the dental students who actually do cleanings and stuff upstairs will check for that. Does everybody know, by the way, that the dental department will do cleanings for you free of charge? Well, now you know. They'll do cleanings free of charge. I have to check whether they're doing it now, because they used to, but with the pandemic, I'll have to check the dental people. But if you need a cleaning and you want it free of charge, go upstairs and have it done. And the dental students are always, they always have somebody with them, so they're not going to do something weird to you. Okay, so larynx. So here's the different subtypes. Glottic cancer. which is what main area, what main part of the body is included in the glottic area of the cancer? It's the vocal cords, the true cords. You remember there's true cords and then there are false cords. Everybody knows that, right? You get that from your anatomy, hopefully. Okay, so glottic cancer, 59%. Supraglottic cancer, 40%. Subglottic cancer, 1%. Because normally a true subglottic cancer is extremely rare. Most subglottic cancers are extensions of the glottic cancers. Glottic cancer is actually the true larynx cancer. So you have supralarynx or sublarynx. So supraglottic or subglottic. Risk factors. What does it say? Picture's worth 1,000 words, right? So smoking and drinking. That's the main risk factors. Incidence of laryngeal cancer, closely correlated to smoking. As head and neck cancer tumors occur 6 times more among cigarette smokers than in non-smokers. Most larynx cancers I've ever treated have been smokers. The occasional one is not, but they were usually secondhand smoke. Standardized risk of mortality appears to have a linear relationship with the increasing cigarette consumption. So now the cigarette consumption, or the true cigarette consumption, has gone down. Therefore, larynx cancers should go down. They haven't as yet. Death from laryngeal cancer is 20 times more likely for the heaviest smokers than for non-smokers. And I don't even know whether you can get unfiltered cigarettes anymore. Has anybody ever seen an unfiltered cigarette? Yeah, they were all the rage 30 or 40 years ago.
My pops.
I don't think they make them much anymore. In fact, I don't think they make them at all anymore. The filter was supposed to filter out some of the nastier stuff. Of course, it didn't really work, but that's the idea. Use of unsulfurable cigarettes or dark air-cured tobacco is associated with further risk. So the air-cured tobacco was the ones that you put in a barn and you just let the air cure. I think that's how cigars are made. So alcohol is a less potent carcinogen than tobacco, but also it's still okay. Oh, I know. Oops. It's coming back up. So alcohol is still a risk factor. That's not good. Oh. Let's try this again. Okay. I don't know, I guess it's Monday. So, alcohol. So do you think that there are obviously various types of alcohol, from wine spritzers to 110 proof alcohol. So what do you think, since I have to log in again here, what do you think is the worst type of alcohol to use?
Probably something like Everclear. higher percentage
Much higher percentage of what?
alcohol.
What type though? Hard liquor, distilled liquor, beer, wine, whatever. What do you think is most
Hard liquor
Probably
or
hard liquor.
hard liquor? Yeah, you're right. It's usually hard liquor that gets you every time. Okay. So let's go back to where we were. I have to be careful what I do, I guess, today. Okay. The use of unfiltered cigarettes, we've done that. Okay. So individuals who use both tobacco and alcohol, these risk factors appear to be synergistic. Gee. And they result in a multiplicative increase in the risk of developing laryngeal cancer. So if you smoke, you have a certain risk. If you drink, you have a certain risk. If you do both, then it multiplies the risk. So other risk factors. HPV, gastric reflux, occupational exposures, which would be things like working with chemicals, etc. And prior history, obviously, of head and neck radiation. Okay, small laryngeal cancers that do not have lymph node metastasis, cure rate of 75 to 95%. If you get these cancers early, very early, then it's almost 100% 5-year survival, which is pretty good. Depending on the site, the size of the tumor, and the extent of infiltration. Advanced disease obviously has a worst case scenario, and supraglottic usually manifests late and have a poorer prognosis. So when we look at the supraglottic cancers, they have a poorer prognosis. Partly because they have a lymph node drainage. Remember, the glottic cancers, or the glottis, does not have lymph nodes. So glottic cancers do not spread via lymph nodes. They have to get into the blood supply. That's why when we get them early, we can cure them very much so. But the supraglottic cancers are and the subglottic cancers all have lymph node involvement, so they tend to be much worse. So in the 1950s, male to female ratio in patients with laryngeal cancer was 15:1. Number has changed to 5:1 by the year 2000. Proportion of women afflicted by the disease is projected to increase in the years to come. Why? 1950s, a lot of women smoked. Not as many as they do now. But if you look at the old movies and the old photographs, there's a lot of women who smoked then. It was the in thing to do. Partly because we were still advertising them on radio and TV. And doctors were saying that certain types of cigarettes were good for your health. Yeah, that sounds weird, doesn't it? But it's true. So these changes are likely to reflect the shifts in smoking patterns, with women smoking more in recent years. And laryngeal mostly affects men, middle-aged or older. Peak incidence is 50 to 60. So 85 to 95% are squamous cell carcinoma, characterized by epithelial nests surrounded by inflammatory stroma. What the heck is that, she says. Well, I'll tell you, because I had to look it up, actually, to be honest. Stroma cells play a central role in an acute resolving to a chronic inflammatory process. So the stroma cells are the cells that actually start the inflammatory process. And keratin pearls are pathogenomic. Here's another one. So keratin pearls are keratinized structures found in regions where abdominal squamous cells form concentric layers. So there you are. And pathognomic is, it just is a big word for saying that it's characteristic of a particular disease. So keratin pearls are characteristic of squamous cell carcinoma of the larynx. So here's some more histologic types. You probably will never see them. The majority of them, as I said, are squamous cells, but verrucous, fibrosarcoma, chondrosarcoma, salivary carcinoma, adenocarcinoma, oat cell carcinoma, and giant cell and spindle cell carcinoma. Where have we seen this oat cell before?
Small cell.
Pardon?
Small cell lung cancer.
Small cell lung cancer, yeah. So here is the anatomy of the larynx. So this is the epiglottis, this is the hyoid. So you have false cords here, and then you have the true vocal cords here. And then you have the thyroid cartilage, the cricoid cartilage, and the trachea. So the glottis would be basically just this area here. The supraglottis would be up here. And the subglottis is below the true cords down to the trachea. So the subglottis would be stop at the edge of the trachea, which is right here. So these are now cadaver specimens, just so that you know. So this is a supraglottic larynx. So here's the epiglottis. Here's the false vocal cords, aryepiglottic folds, and the adenoids here. And if you flip back to the anatomy, you can actually see all these. So this is the glottic larynx. This is the glottis. These are the cords. This is the cricoid cartilage here. And this is the thyroid cartilage down here. So the cricoid cartilage comes around here. So it goes down to here, comes up to here. And this is the cricoid. This is the glottis. These are the cords. So this is a subglottic larynx. Region between the vocal cords and the trachea. So this area here is the subglottis. This is the start of the trachea. You can see the bands. So this is this is the subglottic area. And the pre-epiglottic fat, the anterior and lateral aspects of the larynx, often invaded by advanced cancers. Remember, the larynx will spread through direct spread and then blood spread. Okay, so the lymphatics. So the supraglottic larynx spread to the subdigastric nodes, middle anterior cervical nodes, and then the lower anterior cervical nodes. So the subglottis, delphin node, lower anterior cervical nodes, paratracheal nodes, supraclavicular nodes, and the mediastinal nodes. And then the glottic metastasized to, or the subglottic metastasized to the ipsilateral lymph nodes, but supraglottic tumors often spread to nodes on both sides of the neck. What's ipsilateral mean? Oh, sorry, I thought somebody said something. What? Yeah, so ipsilateral is on the same side of whatever you're talking about. So if you had a left-sided supraglottic lesion, then the ipsilateral nodes would be on that right side. What's the opposite of ipsilateral? Contralateral, yeah. So here is the T stages. Tumor limited to one subsite of the supraglottis with normal vocal cord mobility. Again, this is supraglottis. Tumor invasion of the mucosa, more than one adjacent subset. And T3, tumor limited to the larynx, the vocal cord fixation and or invasion of any of the post-cricoid areas or pre-epiglottic tissues. And T4, tumor invasion through the thyroid cartilage and or extension into anything else, I think. And here's the glottis. Tumor limit T1, which is what we normally get to treat, is tumor limited to the vocal cords with normal mobility. T2, tumor extension to the supraglottis and or subglottis and or impaired vocal cord mobility. T3, tumor limited to the larynx with vocal cord fixation. And T4, tumor invasion through the thyroid cartilage and or other tissues beyond the larynx. Notice not even a sign of lymphatic tumors or lymphatic spread here. So impaired vocal cord mobility. What would that do to the patient's voice? What would, yeah, go ahead.
Make it sound hoarse.
Yeah.
Green.
Make it sound hoarse. And when we treat these patients, we ask them not to talk, or to talk as little as possible, because some people just cannot not talk. So we ask them to talk as little as possible, and if they do, to whisper. Tumor limited to the larynx with vocal cord fixation. That means that the voice is going to be very different from what it usually is. And some of them just cannot make sounds, they have to whisper. And then the tumor invasion through the thyroid cartilage. So here's the subglottis again. Tumor limited to the subglottis, tumor extension to the vocal cord with normal or impaired mobility, tumor limited to the larynx with vocal cord fixation, and tumor invasion through the thyroid, cricoid, and extensions and other tissues beyond the larynx. So here's the nodes. So I'll let you look at these yourselves. So N0, of course, is no nodes. N1, N2, A, B, and C, and N3. And the epiglottis. Frequent location for cancers that arise in the supraglottic. And advanced lesions that may extend laterally to involve the adjacent wall of the piriform sinus or medial to invade the epiglottis. Supraglottis, deep invasion of the paraglottic space, and because of the close proximity, these tumors may extend inferiorly to involve the vocal cords. So presentation, hoarseness. Some people will say sore throat, but the actual presentation is hoarseness. Change in voice in patients with chronic hoarseness from tobacco and alcohol can be difficult to appreciate. The problem is that a lot of people, and if you know a smoker, will know that their voice changes. If you've known them before they smoke and while they're smoking, their voice is changed, and they have the archetypical smoker cough that can alter their voice. So dysphagia is what?
Difficulty swallowing.
Hemoptysis. What's hemoptysis?
Coughing up blood.
Coughing up blood. Throat pain, makes sense. Ear pain. Airway compromise. Why would the airway be compromised?
The mass has grown large enough that it blocks the airway leaving the trachea.
Yeah, that's right. And that means sometimes that they have to do a trach. Aspiration. What's aspiration?
Breathing.
Pardon?
Breathing.
No,
And,
that's respiration.
inhaling fluids.
Inhaling, yeah. So what usually stops fluid going into the lungs?
Glottis,
What?
epiglottis.
Epiglottis. I didn't hear the epi, sorry. That's why I asked. So what does the epiglottis do? If you're talking, then the epiglottis is blocking off the what? If you're breathing, the epiglottis is
Covers the.
covering what?
The esophagus.
The esophagus. If you're chewing and swallowing, the epiglottis does what? It's supposed to block off the airway. So, and then of course you have these people, and I must admit myself included, is you're talking and eating at the same time. What happens? It goes down the wrong hole. And that is aspiration. So you have food and you're talking and you're in a group of 4, if that's allowed these days, and you're talking and eating and you're talking and laughing, and all of a sudden, oops, yeah. And a neck mass, of course, which could be an extension of the tumor. So patients presenting with hoarseness should undergo an indirect mirror exam and/or flexible laryngoscope evaluation. Has anyone been to a doctor where they put this silly little big mirror on their forehead? And no? A head and neck exam? No. Okay, they have what is called a head mirror, which is basically a piece of Velcro that goes around the forehead and there's a mirror stuck in the middle. Looks kind of weird, but anyway. So what does, and then they have, that's where the tongue depressors come in. And then they have a light that goes down your throat. And that's where your gag reflex comes in. They're sticking something down your throat to see how the back of your throat looks and the larynx looks. That's the laryngoscope. And malignant lesions can appear as friable, fungating, ulcerative masses or be subtle as changes in mucosal color. Think of, I can't really explain what a fungating lesion looks like, but I'll find a photograph and let you see it. I don't think there's one in here. Okay, good exam looking for cervical lymphadenopathy, which is what we're talking about for the dentists. Base of tongue should be palpated for masses as well. Restricted laryngeal crepitus may be a sign of proskicoid or retropharyngeal invasion. Okay, so this is biopsy performed in the OR with the patient under anesthesia. Vocal cord nodules, polyps, papillomatous, granulomas. This is where you get all of these actors and singers that go in to have their polyps removed from the larynx because the overuse of their vocal cords. Okay, so direct laryngoscopy we mentioned. Bronchoscopy, which is what? What's a bronchoscopy?
Visual examination of your bronchs.
So in that vein, esophagoscopy.
Same thing with your esophagus.
Yeah, exactly, yeah. Okay, chest x-ray, obviously. Everybody gets a chest x-ray whether they need it or not. CT or MRI, usually CT first. Liver function tests with or without ultrasound, and perhaps a PET. Now, has Mr. Graham gone over CT, MRI, PET with you yet? Don't worry, he will. What's a CT? What's the correct name for a CT or a CAT scan?
Computed tomography.
Sorry?
Computed tomography.
Computer tomography, yeah. MRI?
Magnetic resonance imaging.
And a PET?
Positron emission tomography.
Yeah, okay. So which one doesn't use x-rays?
MRI.
Or actually radiation, I should say.
MRI.
If I said to you which one, yeah, you're correct. If I said to you which one does not use x-rays, kind of, you can include PET in that because it actually uses what? It actually officially uses isotopes and electrons. Positron emissions. So it doesn't actually include x-rays, it uses positrons and isotopes. So officially, you can do that. Okay, so these are vocal cords. So here is something that is definitely not here, since the arrow's pointing, there's something wrong with it, right? So this is a lesion in the larynx, here. And here is a lesion actually on the cord. This is the normal cord. This is an abnormal cord. You can see the difference. So this lesion would stop that cord from doing what it's supposed to do. How do the cords make sounds?
Vibration.
They vibrate. So this one would vibrate very well. This one, however, probably wouldn't work so well because it's not as sleek, if you can use that phrase, as this one. This one is definitely in need of help here. And then you have this. This is a mess, for want of a better word. These are all cancerous. The cord is back there somewhere. But this is what might be called a stage 4 cancer of the larynx. Because it may have started here and spread downwards, spread upwards. And you notice there's something up here and something up here and something over here and something over here. It's a mess. It's probably a stage 4. So pre-malignant conditions or carcinoma in situ can be treated by surgical stripping of the entire lesion. So if we go back, this is probably not a carcinoma in situ, it's probably a stage 1. But they can strip this off of the cord. The cords probably would never be the same, but at least it get rid of the lesion. So their voice may have changed. Same, that happened to, oh Lord, Julie Andrews. Everybody know who Julie Andrews is? Sound of Music? Yeah, okay. She went in for polyps to remove from her vocal cords, and they stripped them and left her voice pretty awful, basically. So she can't actually sing anymore. Or she can sing, but it's not as good as it used to be. And CO2 laser can be used to accomplish this, but makes accurate review of margins difficult. Okay, so here, early stage 1 and 2 can be treated with radiotherapy alone, which again is what we usually do. Surgery has shortened treatment time, but saves radiation for recurrence, but have worse voice outcomes. So we always talk about cosmetic results in radiation. What the patient wants to know what they're going to look like afterwards, and that's what we call cosmesis, or cosmetic effect, or cosmetic results. So the surgery would go in and do what they need to do, but the voice is the cosmetic result. How is your voice going to sound afterwards? And they found that radiation, although it takes a fair amount of time, 6 to 7 weeks, has a better outcome for voice than surgery does. So it has its own complications, however. Before we go on to the next slide, tell me what kind of complications might arise, do you think, from treating the larynx? We're treating the neck. Redness to start with, right? What else? You're treating here.
Sore throat.
Pardon?
Sore throat.
Yeah, okay. Let's go see. So, mucositis. What does that mean? Mucositis. Sorry?
Inflammation of mucus
Yeah.
membranes?
So basically what it's doing is you have the mucus, the phlegm basically is going to get very thick and it's not going to help very much. Odonophagia. Okay, let's go the other one. Dysphagia. What's dysphagia? Sorry?
Difficulty swallowing.
Difficulty swallowing. Odonophagia is actually painful swallowing. Laryngeal edema.
Accumulation of fluid.
So yeah, well, it's actually swelling. Edema is usually swelling. It can be from fluid, but it can just be the tissues swelling up. Xerostomia. Dry mouth. Stricture and fibrosis. So fibrosis means that the parts of the larynx are going to get thick and they won't move as well as they should. Stricture means that they're going to be stuck in one place. Radial necrosis. So what's necrosis, ladies?
Dead tissue.
Sorry?
Dead tissue.
I'm sorry.
Dead tissue.
Yeah, dead tissue. So necrosis is cell death or tissue death. So radial necrosis is tissue death caused by the radiation. Unfortunately, sometimes you have to do that. And hypothyroidism. Hypothyroidism.
Your thyroid is working slower?
Underactive.
So what's hypothyroidism?
Under activity. of the
Yeah,
thyroid.
right, underactivity, yeah. So advanced stage lesions often receive surgery with adjuvant radiation. Most T3 and T4 lesions require a total laryngectomy. Take out the larynx totally. So they've no voice. Small T3 and lesser size lesions can be treated with partial laryngectomy. Okay, chemo can be used in addition with advanced stage, cisplatin and 5-fluorouracil. And here comes the sensitizers, the radiosensitizers. Cisplatin is thought to sensitize cells, enhancing its effectiveness when used concurrently. Unfortunately, the patients get sore just with radiation. And then you get the chemo on top, which sensitizes the cells to the radiation, and that enhances the reaction. Modified or radical neck dissection, presence of nodal disease. Obviously, subglottic or supraglottic would be the ones that would be used for modified or radical neck dissection. So radical neck dissection means that you're taking all of the nodes. Modified, you take just some of the nodes. N0 necks have a selective dissection, sparing the some of the nodes. I can't remember those. Okay, I'll get you those ones. And, N1 have a modified section. So here, again, is subglottic laryngectomy. So mobile cords, no anterior commissure involvement, no tongue-based disease, an apex of piriform sinus not involved for a T1, T2, or T3. Okay. So let's just stop here. Let's go for a break. You probably listened to.
Can you see it?
I mean, kinda.
You probably have a clear shot from right here and there's blood over here.
Look at total laryngectomy. That's obviously removal of the larynx. So the indications for that are T3 or T4, and it's unfit for partial laryngectomy. Extensive involvement of both the thyroid and the cricoid cartilage. Invasion of the neck soft tissues, and tongue base involvement beyond the circumvallate papillae. What the heck are circumvallate papillae?
Taste buds?
Yeah. Taste buds only go so far back. So here is I must admit, not so good.
Got a small chair. Really small.
It's actually pretty, even I can't see that, so, but here is the total laryngectomy. Here is a hole basically to the outside. They basically take a hole or take the larynx out, and they're left with what is called a stoma. Here. And this is what it looks like when it's healed. Normally when you get it, you have a tube going in, and it starts off with a metal tube. And then they'll replace it when you come for treatment with a nylon or plastic, usually nylon tube. Why would we have to replace the metal when we're treating patients?
I would imagine it would interfere with the beam.
Yeah, some of these things, you don't have, simple is better. You don't have to overthink them. You know, if you have a metal tube in there, then it's going to affect the treatment. It's going to make this area even sorer than it is going to be. So they take out the metal tube, the trach tube, and put in a plastic one or a nylon one, or whatever they're making them out of these days. But normally when they're healed like this, they're left like that. So what would be the problem with having a hole in your neck? Just going about your everyday business.
Getting stuff stuck in it.
Yeah, okay, yeah. I'm thinking a little more mundane. So what about having a shower?
Oh, no.
Can't ever go swimming, can
So this is the kind of thing that you actually don't think about, right? I mean, you have this hole in the neck. How do you have a shower?
you?
Yeah, I mean, you can turn your back to the shower, but you still get to water here.
Saran wrap.
About putting a gauge in it.
But this is where you breathe, dear.
Yeah.
So you can't really,
It's gonna hold your breath and.
Yeah.
I hope you-
what about going out in the wind?
Oh, no.
Yeah.
So you've got stuff kicking up. So what normally they do, and one of my patients many years ago had a little cottage industry going with herself, and she crocheted little, she called them neck bibs. And they were like, if you'll excuse me till I take this off, they were like little things that go around the neck and they hang over the stoma. And they keep the dust and stuff out of the neck, and they can still talk through it. But it was, and she made little fancy ones for ladies and a little more macho ones for the guys. Of course, the guys are want to do that, but dust, water, etc., etc., etc. And as I said before, I've seen people smoke out of those. They put the cigarette up and, smoke. Yeah. Anyway.
Yeah, what is the point in even getting treatment?
Yeah. Well, that's it. And this is something that always comes up with patients for larynx, with patients that are lung patients, that we had a physician who told a couple of patients that they wouldn't treat them. He wouldn't treat them unless he decided to stop smoking. And he was, how shall I put this, raked over the coals by his boss for suggesting that. He basically was accused of blackmailing the patients. He wouldn't treat them unless they stopped smoking. I see his point. However, I can also see the other side. Is it going to be any better if patients stop smoking while we're treating them? Is it? Is it gonna make the treatment work better? No. At this stage, if they have larynx cancer or if they have lung cancer, it doesn't matter one little bit whether they're still smoking or not. It will just make them more miserable. But as far as the treatment concerned, it's not gonna matter one little bit. So most patients, when they find that we're treating them and they can't smoke because it hurts too much, they'll stop on their own because the chemicals in the tobacco will hurt, will make the irritation even more irritating. So, no, it doesn't make any little bit of difference whether they're smoking or not. It's just a case of, it's better if they don't smoke, but you can't force something like that to stop smoking because they're addicted. And there's they say that actually tobacco is more addictive than heroin. So it's actually worse to try and stop smoking than it is to try and kick heroin. So what do you do? So let's go back to where we were. So I believe we're at, okay, there we go.
I showed
Okay.
my husband some of the pictures on these slides and in this book.
Yeah.
He likes to smoke a hookah, but a hookah is tobacco.
Oh yeah. Well, hookah's just as bad.
Yeah, I know, that's what I said. And
Yeah.
he was like, don't show me. Don't. I was like, look, what do you mean don't show you? You're gonna see it eventually in the future.
Yeah. Yeah.
But
Yeah, I know when I was doing this, when I was actually training for this thing, for this course, and my dad was a smoker. And I used to leave pictures, well, obviously not this book, but pictures of my book open at the lung cancer thing. And it made it worse because my aunt had just died of lung cancer. And she was a non-smoker. But I remember, yeah. So it has its pros and cons. I remember sitting at the dining room table one day studying. And I was studying, as luck would have it, or as fate would have it, male reproductive tract. And one of my uncles came in and said, and leaned over my shoulder and looked at my dad and he said, "Do you know your daughter's studying dirty pictures?" Oh dear. Anyway, parents, what do you do? Can't live with them, you can't shoot them. Anyway, sorry. Oh dear, okay, let's go back.
You're on slide 58.
58, yeah, thank you. 58, so here we go. So let's try this again. So paranasal sinuses. What are paranasal sinuses? Tell me the paranasal sinuses. Without looking at the book, ladies and gentlemen, please. What are the paranasal sinuses? Name them. Without looking at the book.
I don't know that.
Huh? There are two here. What are these?
Maxillary sinus.
Maxillary sinuses. Okay. There are two up here,
The frontal.
frontal. There are two here.
Lacrimal?
No.
It's
Ethmoid?
endpoint, yeah. I couldn't
Ethmoid?
remember.
Yeah. Those are the main
Because
ones.
when he pointed here, I was like, the endpoint.
No, here.
Yeah.
Here.
I got the mask.
Yeah. Okay. So, which is the largest?
Probably. I'm gonna throw a guess.
Okay.
Maxillary.
Let's do this. Let's go on and see what we can find. Okay, so the incidence is relatively rare. It's only 2,000 and cases annually in the US. Gender is mostly male. Age is around 60-ish. The book says over 40, but still more common in Asia and Africa. So causes, unfortunately, are unknown. Occupational exposures, so exposures to chemicals, usually. EBV,
The Epstein-Barr virus.
Epstein-Barr, yeah. And, of course, smoking.
Every time.
So here they are, maxillary sinus. They call the nasal cavity, but we'll just ignore that one for the moment. Ethmoid sinuses, frontal sinuses, and sphenoid. So symptoms, asymptomatic. What are the sinuses? Anatomically, what are they? Anybody? What are the sinuses?
Openings where air flows through, and they're moistened by the mucus lining.
Yeah? Okay, but more simple than that. They're holes in the bone.
holes.
Sinus is a hole. So, that's what they are. So asymptomatic, if you have a tumor in a hole, is it gonna cause any problems? Early, anyway.
I mean, if it's blocking it well enough, yeah.
That's what I mean, so early sinus tumors do not cause any symptoms. Later on they will, but at the moment, no, they wouldn't, the small ones wouldn't. Because they're in a hole, they're not damaging anything, they're just filling up the hole. Eventually they will cause. What would they think the first is given here? Congestion. Think sinusitis. If anybody's ever had sinusitis, think bad sinusitis. That would be one of the first ones. Epistaxis, which is what? Epistaxis. Oh, guys. Epistaxis. Nosebleed. So pain, drainage, and loss of function. So benign, you can have benign tumors, and they're papillomas, or the most common one, as it is in all of the head and neck cancers, is squamous cell. Adenocarcinoma and lymphomas, or erythroblastoma, verrucous carcinoma, small cell, teratomas, sarcomas, and of course, metastatic disease. But the most common one would be the squamous cell. Metastatic disease is uncommon, but if it does, lung, liver, and bone, does this sound familiar? And nodal disease. So, the problem with sinus tumors is, if you think about this, you have a tumor growing in your maxillary sinus, or maxillary antrum, you may hear that. So you have a tumor growing here, and it grows and it grows and it grows, and it finally causes you what you think is sinusitis. So you go into the doctor, he sends you to a head and neck person, he looks in and says, we need to look at your sinuses. So they'll send you for what is called a sinus X-ray. And then, as my husband so quaintly put it, you have your sinuses drilled or plumbed. That's what he called it. He had bad sinusitis, and they sent him in to have his sinuses plumbed. That's what he called it. And that's basically what they do. They go in and they, obviously what they're looking for is excess phlegm or excess mucus or excess whatever it is, or inflammation or infection, because you're getting this sinusitis. So they go in and they find the tumor. However, because those tumors do not cause any symptoms until they're advanced, if you have a maxillary tumor here, where is it going to spread?
Eyeball.
Into your eye. Where else? So you've got here. Where is it going to? Into your eye. What goes, what's south? What's inferior?
No.
Mouth, into the hard palate. Or where else? What's lateral or medial, actually, in this case? Into the nose. So this is where you don't get nodal spread a lot, you don't get a lot of, widespread metastasis until it's very late. What you will do is get direct spread. So that would mean with the maxilla, it would go into the orbit, it would go into the hard palate, or it would go into the nose. And that's what we have to cope with if we're treating this. So if you have a maxillary lesion here, you may have to treat the eye. You may have to treat the hard palate, you may have to treat the nose. However, we'll get to that in a couple of minutes. So, let me get my glasses so I can see. Okay, so site specific for surgery. So they would go in and hopefully clear out as much as they can from the sinus, whatever sinus it happens to be. I tend to use the maxilla because it's easier to describe. So chemotherapy is not used very often, but it is coming back. It is coming back. But again, it's not used an awful lot. So radiation. Pre-op. So what we're looking at is we're treating this patient preoperatively. We're trying to what it's called is debulk. So we're using radiation to make the tumor smaller to give the surgeon a better chance of removing it all. So that's what they call it, is debulking. And the treatment details are what they call site-specific. So we'll call again the maxillary antrum or maxillary sinus. So what we're going to do here is we're going to do a patient, that's the nose, and he's got swelling here. Sorry, I didn't mean to do that, but anyway, it helps. So the tumor is sitting here. So what you're gonna do is you have to treat this without treating the other side, or without treating a lot of the other side. So you can do two things. You can do, actually three things. So what you can actually do is do a field in like that, and then a field in like that. So that will give you a nice field. However, that won't give you an even dose throughout that area. Why not? Why won't it give you an even dose?
Because one's coming through the anterior portion of the skull and one's going through the superior.
No. This is going this way, and this way.
The tumor's closer to.
Sorry? Yeah. So what I'm aiming for is an even dose throughout here, but you can see that this is curved. So what do we have to do in order to make it even?
Use a wedge.
Wedges, yeah. So what we do is we'll put a wedge here, and we'll put a wedge here. If you're using wedges on this type of field, you always have the thick ends together, or the heels together. Heel, thick end. And that will even up the dose throughout this area. Make sense? That's one way of doing it. Another way of doing it another way of treating this is do what is called a wedge. Well, this is a wedge pair, but we also can do it this way. We can do it this way. So one in like this, and one in like this. And again, you have to have a wedge. Oh, wrong way. You have to have a wedge this way, and a wedge this way. So they're both wedge pairs. The other way we could do this, and this is only if the lesion is very superficial. So it's under the skin, but it's really close to the skin. We could do one single electron field. That's what we could do. However, you have to remember that you're going through bone. And electrons don't do well with bones. So it's only in use if you can do that. The other thing I've seen used also is we do an electron and a photon at the same time. Well, one after the other. Don't do it all at the same time. We do a photon and then an electron. And the photon would get through the bone, and then the electron would help treat the tumor. That's for the maxilla. So the dose would be around 6,000, 7,000 centigrade, depending on what you think the patient can tolerate. It's a very rare disease, however, in some parts of the country. You get a lot of them, but nobody knows quite why, because you have no real understanding of what your risk factors are, apart from occupational. So, maxillary sinus, early stages. And as I said, you very rarely get an early stage sinus. And that would be 80%. Unresectable tumors, so that means that tumors are so big that the surgeon can't handle them. We'd have to treat them. And that would be about 20%. Ethmoid, so low grade and high grade. So what does low grade and high grade mean? What's that a rationale for? So what does low grade mean as opposed to high grade?
Is that regarding differentiation? Cell differentiation?
Somewhat, yeah. It's the aggressiveness of the tumor. So if you have a low grade tumor, it's not aggressive. If you have a high grade tumor, then it's extremely aggressive. Sorry, itchy nose. Okay. So low grade, because it's not aggressive, you could do a 90% survival. A high grade, unfortunately, is 20%. Those are the most common, maxillary sinus and ethmoid. So salivary gland, or salivary gland, call it what you will. What is the largest salivary gland in the head and neck?
Is it submandibular?
No,
Sublingual,
no,
so it's broad.
yes.
One of those.
Had to be
It was
one
one of
of the three, yeah, you
We
didn't
did
have
it
much.
eventually.
Yeah, you didn't have much less, okay. So, yeah, salivary gland, the most common is the parotid. So where do you find the parotid gland? Whereabouts is it? How do you find the parotid gland? Anybody?
Are they at the base of the tongue?
Somewhat. So to find the parotid gland, do you remember me telling you the, how to find the pituitary, where we have 5 centimeters out and 5 centimeters up? Well, for parotid, it's 5 centimeters out and 5 centimeters down. So 5 centimeters out would take to here, 5 centimeters down would take to here. So it's about there, somewhere,
From the carotid, you said?
the parotid.
5
Oh,
centimeters.
excuse me,
I'm sorry, from what point?
parotid
When you say, you mean from the same spot, from the?
from the EAM.
EA, okay.
Yeah. So, it's rare. Age again is similar, 50s. Gender is again usually male. And deaths approximately 700 annually. So it is extremely rare. Causes are unknown, of course. Risk factors, radiation, occupational exposure, again, dealing with chemicals, diet, tobacco, and family history. So here are their parotid, submandibular, sublingual, and minor. So there's 4 actually, 3 plus the minors. So, the symptoms usually is a mass. Here, or wherever. Pain,